Hello everyone, welcome back. This is Dr. Giuliano. Now we're going to talk about generalized anxiety disorder. Generalized anxiety disorder is frequently associated with a lot of other mental disorders like depression, panic disorder, and agoraphobia. The mean usually occurs with the mean age of onset in the late teens to the early 20s, and it actually is found in higher rates with women and the elderly. The course of the disease is very chronic. It has a high percentage of relapse and unfortunately low rates of recovery, and the likelihood of a complete remission at 2 years is only 25%, and this is going to be lower than some of the other anxiety disorders that we'll talk about. The majority of patients with generalized anxiety disorder will eventually develop another mental disorder. And some risk factors for generalized anxiety disorder include family history, increase in stressors, and a history of physical or emotional trauma. And I want to talk about the DSM-5 diagnosis for generalized anxiety disorder next. First, I want you to focus on the top box here. They need to have all of these criteria that are listed below. So the first bullet is excessive, and it's important that we really touch on that word, excessive anxiety and worry. And it might be about a number of events or activities, and these symptoms usually occur on more days than not, and these need to occur for about 6 months in time. They have to be difficult to control, and they really need to cause significant distress on their day-to-day activities, their social life, how they're doing at their job. And they have to have at least 3 of the ancillary symptoms listed in the box below, but only one of these is required in children. Some of these they may feel restlessness, like they're on edge. They may be fatigued, they can't concentrate, they may be very irritable, have a lot of muscle tension and sleep disturbance. They may not be sleeping well. And with all the anxiety disorders that we'll talk about with the last box, it needs to make sure that the focus of the anxiety isn't due to something else. So it's not actually panic disorder or OCD or some other mental disorder, and it can't really be due to a drug either or a substance abuse problem. And it also can't be organic or made up fictitious. Now, there's 2 main types of symptoms in generalized anxiety disorder. We have our psychological symptoms. These include irritability, poor concentration. They might be very sensitive to noise, sleep disturbances, and difficulty falling asleep, versus our somatic or physical symptoms. These include sweating, dry mouth, rapid heart rate, or urinary frequency. Maybe they have some epigastric discomfort, diarrhea, they may hyperventilate, they may be short of breath, dizziness. So you can see there's lots of different physical symptoms that these patients can have. Our goals of therapy with generalized anxiety disorder, our first goal is really going to be reduce the severity, duration, and frequency of all of these, both psychological and somatic symptoms. In long term, we really want to try to prevent as much of these symptoms as possible, improve their quality of life, and we want to see about a 50% reduction in their baseline Hamilton Rating Scale for Anxiety, or the HAM-A scale. Another way, this is typically classified in the literature as a response to therapy, whereas remission has different numbers associated with that. Now, we also want to prevent relapse from occurring. So what are some of our treatment options that we have available for generalized anxiety disorder? Well, one of the first ones that I want to talk about is the non-pharmacologic therapies. Now, there is psychotherapy and cognitive therapy, and one type of cognitive therapy we're going to talk about a lot throughout these videos is cognitive behavioral therapy. And all of the anxiety disorders, this has really been, it's usually the one that's studied the most. It's a specific type of cognitive therapy that that is focused on both their thinking and their behaviors, and trying to correct those with this type of therapy. Now, there's varied results when comparing CBT versus medications as first-line treatment in generalized anxiety disorder. Um, the advantages, of course, over pharmacotherapy may include lack of side effects the patient might prefer. The issue is that cognitive behavioral therapy is not always widely available, and it does require specialized training for whoever's administrating the training itself. It does entail weekly sessions, and these sessions last for about 12 to 20 weeks, so it is a significant amount of time that they'd be putting into this type of therapy. There's other non-pharmacologic therapies, such as self-regulatory therapies, stress management, meditation, exercise, and really it's important for these patients to avoid CNS stimulants, alcohol, excess coffee, that can precipitate some of their anxiety symptoms. Now, pharmacologic treatment will be only initiated in patients that are having symptoms with significant functional disability. So they may not be doing well at work, or maybe they're not going out with their friends like they used to. And benzodiazepines are going to be the most effective in treating the somatic and autonomic systems of generalized anxiety disorder, while the antidepressants are going to be more effective in treating those psychic symptoms that we talked about, or the psychological symptoms. So some of the general treatment principles for generalized anxiety disorder: therapy should be continued for at least 1 year in these patients. If the patient's initial response is inadequate, then the dose should be increased as tolerated, and it should be maintained for at least 8 weeks. If a patient does have a partial response, then you may want to put them on, have a little bit of a longer trial, maybe go up to 12 weeks, make sure you're maximizing the dose of the medication, and you can consider combination therapy. Studies do suggest that a reduced relapse rate compared to pharmacologic treatment alone, but there isn't as much evidence for combining medication as there is for combining psycho and pharmacotherapy. You can consider a benzodiazepine and an antidepressant, especially if those initial anxiety symptoms are very severe. Augmentation has been used in patients with partial responses, which means they add on an additional agent to try to get to that full response, or that greater than 50% reduction with their HAM-A score. And I also have put a specific note in here. Pregabalin has actually had an increasing number of studies showing efficacy in generalized anxiety disorder. So I actually moved that into the second-line agents. Compared with last year, I used to have it as an alternative. So some of our drugs of choice for generalized anxiety disorder for our first-line drugs, and the first-line drugs do have an overall higher remission and response rate. And these include duloxetine, escitalopram, paroxetine, venlafaxine, and sertraline. So our SSRIs and SNRIs. And then our second-line agents being benzodiazepines, buspirone, imipramine, which is a tricyclic antidepressant, and then pregabalin. Some of our alternative agents could include hydroxyzine, mirtazapine, gabapentin, citalopram. Some of our antipsychotics may be more last-line agents. And when we're choosing the drug, we want to think about special populations. So if we have a pregnant patient, when pregnant patients that have GID, they are at risk for developing. When patients are pregnant in general, they are at risk for developing generalized anxiety disorder or worsening of symptoms if they already have the disorder itself. So what should we use in our pregnant patients? Well, buspirone may be safer than some of our other choices. Benzodiazepines should not be used. During the first trimester, if benzodiazepines are used, the baby can develop oral clefts, and during the third trimester, they may develop floppy infant syndrome or neonatal withdrawal, which will require an extended stay in the PICU. If used, clonazepam and lorazepam are the preferred ones if they have to be used. SSRIs do not appear to be teratogenic for the most part. There are some reports of neonatal toxicity when receiving these in the third trimester, and especially paroxetine has been shown associated with cardiac malformation. So this is definitely something you want to avoid in a pregnant patient. And just realize that antidepressants do cross into the breast milk. Now, in our elderly patients, these patients may experience drug accumulation secondary to decreased capacity for oxidation and changes with volume of distribution. I usually recommend agents with short or intermediate acting for benzodiazepines without active metabolites such as lorazepam. Elderly patients are also very sensitive to CNS adverse effects of benzodiazepine, and they can actually have a paradoxical increase in anxiety for some patients, so you have to be careful in the elderly population. With children, there have been certain SSRIs and benzodiazepines that have been studied, although none of them are FDA approved, and they have shown efficacy. There are reports of hostility, suicidal ideation, and self-harm with paroxetine in children. And at the very bottom of this page, there's a black box warning on all SSRIs that talk about the increased risk of suicidality. And you can read through this entire paragraph, but what this study showed is that there was almost a doubling of risk in these patients for attempting suicide, although none of these patients were actually successful in the process. So you have to be careful with these in children, and this is just the carryover of that chart. As you see, the average risk of events of attempt suicide was 4% versus 2% in placebo. Now, this is a treatment algorithm for generalized anxiety disorder, so this can help you sort of decide, okay, how do we actually treat these patients? What should I follow? What are the rules? So if patients need acute relief, you can consider using benzodiazepines, because remember, when you initially start that SSRI or SNRI, they can have some increased anxiety within those first few weeks before the drug gets to its full effect. So you might decide to use a benzodiazepine. Just realize that there are a lot of side effects with benzodiazepines, so you need to weigh the risk and benefits. If they do not need acute relief, you can start with the SNRI or SSRI. You judge the response after 8 to 12 weeks. If they don't respond, you can switch to another SNRI or SSRI, but if there's a partial response, you can consider augmentation with one of those alternative therapies in the table previously. If they do have a response, we're going to continue therapy for 12 months. But if they fail again, so they fail once, then they fail again, we consider another SSRI, maybe a TCA or buspirone or pregabalin. And then if they continue to not have adequate response, we may want to add a benzodiazepine on board for a short period of time. So benzodiazepines' place in therapy is really going to be for this rapid relief of acute symptoms. It should not be used alone to treat generalized anxiety disorder, but they are very helpful adjuncts to reduce symptoms to return the patient to normal functioning. It can be used as an adjunctive agent for sleep disturbances right when they're starting the antidepressant therapy. And it can be utilized long-term in selected patients who have a lot of failures of different therapies or can't tolerate tapering down the benzodiazepine dose. So there's some important considerations that we want to talk about when we are reviewing benzodiazepines. And one of those is the use in elderly patients. Agents that undergo conjugation are preferred, um, and ones without active metabolites, again, that's going to be like, usually we're going to end up using lorazepam for these patients. If you look at the chart, oxazepam would meet that criteria also. Efficacy rates are usually about 65 to 75% within the first 2 weeks, but the optimal duration of therapy is really unknown for benzos, and it's best to keep them on short term as possible. Long term use is controversial. And the reason why we're really trying to avoid benzodiazepines is the side effect profile: drowsiness, sedation, psychomotor impairment, anterograde amnesia, physical dependence. And then when patients are on it for a long period of time, they're really, really hard to get off of these drugs. Abuse is usually rare with benzodiazepines, but if they have a history of substance abuse, they may be more likely to abuse benzodiazepines. And it can lead to dependence in all patients, so when you take it away, they will have withdrawal. Withdrawal will increase the severity of the original symptoms, and it can actually add on a whole host of new symptoms with withdrawal, including insomnia, restlessness, muscle tension, irritability, nausea, malaise, seizures. That's what the fill in the blank part is there. Very important to know. Blurred vision and diaphoresis, and that's why you can't abruptly discontinue benzodiazepines. You can taper the dose by no more than 25% per week, and you may have to even go slower with longer duration of therapy. I've had patients where I've had to decrease the dose by 5 to 10% every 2 weeks because they had been on these drugs for 50 years. Taper does not always prevent withdrawal, so you may have to taper differently in patients. And this is a rough guide. This is what you should know for your test, though. If I ask you to taper a benzo, and you can see the different lengths of treatment respond to different lengths of taper. For patients that have been on it for over a year, they're going to need at least 2 months, and they may need up to 4 months or even longer for their taper of benzodiazepine. Now, there are a number of drug interactions with benzodiazepines, with diazepam, alprazolam, clonazepam, and lorazepam. So just keep these in mind as you think about which benzodiazepine you are going to prescribe, especially in elderly patients where they might already have increased levels of the benzodiazepine itself. Buspirone is an agent that we can use in generalized anxiety disorder. It's a non-benzodiazepine anxiolytic, and it doesn't have any anticonvulsant or muscle relaxant or hypnotic or motor impairment or dependence properties, which is very attractive. So it doesn't cause dependency or withdrawal. The disadvantage is that it takes a little bit longer than benzodiazepine to work. It's second line due to its inconsistent efficacy reports and its delayed onset of action. And it doesn't work for other anxiety disorders like panic disorder. It is effective for the psychic symptoms, but not for the somatic symptoms. So if they're having those physical symptoms, it's not going to work for that. The half-life of buspirone is about 2.5 hours, and drugs that inhibit CYP3A4 can increase the levels of buspirone, and inducers like rifampin can decrease the concentration significantly. Adverse effects include things such as GI upset, excitement, dizziness, headache, nervousness, lightheadedness. You can see a paradoxical increase in anxiety in some patients, but it is associated with a lot less sedation than benzodiazepines and less sexual dysfunction than other anxiolytic agents, and that can be important, very important for certain patient populations. Antidepressants, so these are going to be our first line agents, our SSRIs, SNRIs, and since depression is frequently associated, antidepressants are often considered first line, like I just said. These are the ones that are FDA approved: venlafaxine XR, duloxetine, paroxetine, escitalopram. And actually, fixed dose paroxetine has been shown to be superior to escitalopram in one study, although we usually say that the SSRIs are usually a class effect, but if patients are failing therapy and they haven't tried paroxetine, it might be something you consider. Even though not FDA approved, citalopram has been shown to be effective for the treatment of generalized anxiety disorder, and imipramine is considered when patients fail to respond to SSRI or venlafaxine. And like I have mentioned a few times, the anti-anxiety response is delayed by 2 to 4 weeks or longer in these patients. SSRIs do have similar efficacy to TCAs, but they do have a more favorable side effect profile. One study actually showed that a number needed to treat of 5, which is pretty impressive, showing that 1 out of every 5 patients that you treated with SSRIs would have less side effects, basically, than TCAs. And paroxetine and escitalopram are only agents, are the only agents approved, but have also been shown to be efficacious in reducing the severity of GAD symptoms. Our SNRIs, such as venlafaxine and desvenlafaxine, have been shown to be effective in treating anxiety. Now, desvenlafaxine has not, but venlafaxine has been FDA approved. Now, some of the side effects of these medications include higher blood pressure at higher doses. These can cause nausea, dyspnea, insomnia, constipation, and sweating. The extended release is nice because it allows for once-a-day dosing. Duloxetine is another SNRI that has been shown to be effective. And in an 8-week study of patients over age of 65 with depression, 60 milligrams of duloxetine significantly reduced psychic anxiety symptoms in depressed patients. And also another study of about 500 patients evaluated the safety and efficacy, and they saw a reduction in core anxiety symptoms. Tricyclic antidepressants, the most commonly used agent in generalized anxiety disorder is imipramine, but due to the side effect profile, it should not be considered until patients fail to respond to an SSRI or SNRI. And there are a variety of other miscellaneous agents that have been studied. Hydroxyzine, in a small study, was shown to be 86% effective, although it's only considered an alternative agent because more studies are needed. Kava, which has been shown to be more effective than placebo as an herbal medication, but can cause significant hepatotoxicity, so we're going to avoid this drug for our patients. Propranolol may be used as an adjunctive agent for patients with significant physical or cardiovascular symptoms, like that palpitations that we talked about as one of the somatic symptoms of generalized anxiety disorder. And then we have gabapentin, pregabalin, and tiazabine that have also been studied. And I talked about pregabalin use you may see increasing for generalized anxiety disorder. So that is the end of generalized anxiety disorder. Next we'll be talking about panic disorder.